Welcome. Today we're going to speak about tuberculosis. By the time you finish this session, you should be able to speak comfortably about the burden of tuberculosis, who is most affected by it, the risk factors for tuberculosis, the health, social, and economic consequences of tuberculosis, and what evidence suggests can be done to address tuberculosis. Let's explore some of the basics about what we'll call TB for tuberculosis. Let's explore some of the basics of TB disease with the help of our students. Elizabeth, what is TB?
TB is a communicable disease that is only caused by mycobacteria.
Okay, a bacteria called Mycobacterium tuberculosis. It's a bacterial communicable disease. And Vivek, how is TB spread?
Spread in the air by people coughing or breathing.
They can even singing. It's spread through aerosol drops. People breathe in TB from other people who are ill with TB disease or certain forms of TB disease. Rachel, what part of the body does TB affect?
TB can affect any part of the body, but primarily the respiratory system.
Okay, it can affect, this is really important because people who know about TB often think it only affects the lungs. It primarily affects the lungs, but you can actually have TB disease in any organ of your body. Yafet, what are the symptoms of tuberculosis?
Yeah, so one symptom is that someone infected with tuberculosis will cough for at least 3 weeks. Also, general weakness, weight loss, night sweats are all other symptoms as well.
All true. And Emily, is TB curable?
Yes.
And what forms of TB are curable?
Well, if your TB is not drug resistant, then it will be easier to cure. But if it's drug resistant, it could be much harder.
Right. So drug susceptible TB is clearly a curable disease. Drug resistant TB, which we'll talk about, is much more difficult to treat. I've always found, as I say to my students, TB is one of my favorites, and one of the topics in which I've always had an enormous amount of interest. And I find tuberculosis to be especially interesting biologically, though I'm not at all a scientist. It's important to note, for example, that if you're exposed to TB, a number of different things might happen. One is nothing might happen. You can be exposed to tuberculosis and not get infected at all. Another thing that might happen is that you can be exposed to tuberculosis and become infected but not have active TB disease. In this case, your body, if I might use the word, kind of walls off the infection, and inside of you, you have what we call latent TB, but you don't have active TB disease. The third choice, and not at all a good one, is that you can become exposed to tuberculosis and actually get active TB disease, as Rachel has said, either in your lungs or in other organs of the body. It's also important to note that about 1/3 of the people in the world have latent tuberculosis. This is really important because it turns out that if these people become immune compromised, for example, through undernutrition, diabetes, old age, that latent TB can emerge as active TB disease. But people with latent TB do not spread TB. And as I mentioned, but people with latent TB can develop active TB disease. It's also especially important to note this important relationship between TB and HIV. An important share of the people with TB have HIV, an important share of the people with HIV have TB. And people with HIV, because HIV compromises your immune system, are 30 times more likely to have active tuberculosis disease than people who are HIV negative. Now, the recommended approach to diagnosing tuberculosis has been through bacteriology, and that is you do what they call sputum spear microscopy. You cough up spit, they put it on a slide, and they look on the slide for the tuberculosis bacteria. This has been less than perfect, and more new techniques are being developed. And these are molecular techniques which with both countries, which a number of countries now, especially in conjunction with the global community as a whole, are beginning to use more and more. The next graphic speaks to the burden of tuberculosis disease, what we'll call basic TB facts for 2013. In 2013, there were 11 million people in the world living with TB. There were about 1.5 million TB deaths. It was at that time about the same as HIV. More recently, I think people have said that as HIV deaths have declined, and TB2, TB is now, I think, considered to be the leading infectious cause of death in the world. That year, there were about 300,000 estimated cases of drug-resistant tuberculosis, or about 3.5% of new cases. And I believe in a report that has just come out where the numbers have been revised upward due to better surveillance, that the World Health Organization is suggesting that as many as 480,000 people might now have drug-resistant TB, which would be close to about 5% of all of the new infections. And when we look at the distribution of prevalence, we see that, and this is by World Health Organization and region, we see here how the disease is distributed across the world. And it's also important to note that two large countries, India and China, contain about 35% of all of the people with tuberculosis in the world. It's also essential to understand that about 60% of the people who get active TB disease each year are men, although TB is also a major killer of women. In addition, we should note that about 13% of the people with new cases of active TB disease were HIV positive. Another important fact is that TB was the 10th leading cause of death in the 2010 Global Burden of Disease study. Moreover, we see that about 75% of the people newly infected with active TB disease were 15 to 54 years of age in their so-called productive years. It's also critical to understand that TB is an important disease for children. However, its burden is certainly underestimated since it's hard to diagnose TB in children. Okay, can I just start with it's critical, Doug? Yep. It's also critical to note that TB is an important disease for children. However, its burden is certainly underestimated given how hard it is to diagnose TB in children. The World Health Organization, in fact, estimates that 140,000, or almost 10%, of the 1.5 million people who died of tuberculosis in 2014 were children. Nonetheless, tuberculosis is an important childhood disease, but TB is hard to diagnose in children, and almost certainly the share of kids that we think have tuberculosis, especially in some of the low and middle income countries, is higher than those that actually get counted. TB mortality has fallen almost 50% since 1990, with the largest decreases in mortality occurring since 2000. And of course, getting people on antiretroviral therapy or HIV positive is also good for reducing the burden of tuberculosis, because those people will suffer immune suppression less and be less susceptible to tuberculosis. Now, drug resistance is a really important issue in the control of tuberculosis. Drug resistance occurs when microorganisms such as bacteria change in ways that render certain medications no longer valuable in addressing them. And for TB, as in malaria and as in many other diseases, drug resistance is a really fundamental issue. Sometimes drug resistance arises when people become, when isoniazid and rifampicin no longer work on those people, no longer work on the TB from which they suffer. But sometimes they can have what's called extensively drug-resistant tuberculosis, and even more of the TB drugs that we have fail to address the tuberculosis that's making them so sick. Now, you can acquire resistance essentially in two ways. One way is if you don't complete all of your treatment, then the TB inside of you might in fact become resistant to the drugs to which it's normally susceptible. But another, if God forbid, for example, Vivek had drug-resistant tuberculosis and I was exposed to his TB, then it would be possible that I would get directly from Vivek drug-resistant tuberculosis. As I said, about 5% of all of the cases of active tuberculosis disease in the world are thought to be resistant. And the highest burdens of multi-drug resistant tuberculosis are in China, India, and Eastern Europe. And this notion of drug resistance reminds us of the imperative of ensuring that TB control programs work well, that people take all of their drugs, as we'll talk about in a minute. TB has very large economic and social consequences. When people become sick with tuberculosis disease, they can be out of work for quite a long time. And studies that were done, for example, in India suggested that people lost on average 3 months of their wages and took on debt and were often immiserated because of falling ill with TB. There's also a substantial amount of stigma associated with tuberculosis disease, and most especially among women, who often are shunned by their partners or their families when they get TB. And there have even been some macroeconomic studies that suggest that every increase of 10% in the incidence, in the number of new cases of tuberculosis, was associated with lower annual economic growth between 0.2 and 0.4%. Now, I should have mentioned, though you probably sensed it already, the people most at risk of tuberculosis are poor people, immune-compromised people, and people who live in crowded circumstances. Tuberculosis is not a disease that affects better-off people who live in nice houses where everybody has a fair amount of space. I repeat, this is another disease that primarily affects the poor, those who are immune-compromised, and those living in crowded circumstances. It's also important to note that smoking, excess alcohol use, and diabetes are risk factors for TB. And there's increasing concern about the extent to which the growing prevalence of diabetes in low and middle-income countries could unleash cases of active TB disease in those countries which have a high prevalence of latent tuberculosis. There is a vaccine for tuberculosis. It's generally referred to as BCG, an abbreviation for the French name that it has. And the BCG vaccine is a standard part of the expanded program on immunization for children. The vaccine reduces severe tuberculosis in children, but because children are not important transmitters of TB, and due to what they believe is the variable efficacy of the vaccine in different circumstances, the vaccine has very little impact on the overall incidence or prevalence of tuberculosis. Rather, the control of TB depends on effective treatment of active tuberculosis. And again, we have to remember that implementing a program of TB control that's not very effective in some respects is worse than not implementing it at all, because the failure by people to adhere to all of their therapy can breed drug resistance. The World Health Organization recommends a 6-month regimen for drug-susceptible tuberculosis disease that's provided to people on an outpatient basis. And there are 4 drugs that people take for 2 months, and then 2 months that people take, 2 drugs, that people take for the 4 months after that. Patients must adhere to this very lengthy regime, which leads to some of the issues and challenges that we'll talk about. And the World Health Organization and other organizations working with it have developed an approach called Directly Observed Therapy Short Course, which is intended to enable people to adhere more effectively with their therapy. And in this case, for example, if I had active tuberculosis disease and was placed on therapy, the program might recommend that Yafet, as the teacher in our village, would be the person who would get the drugs. I would go to him every day. He would watch me take my drugs. He would ensure that I take them. He would ensure I go at the end of 2 months to be rechecked and at the end of 6 months to be sure I'm cured. And he would report to Emily as the supervisor if I didn't show up for my drugs. And that might be a priest, it might be a minister, it might be a village chief, it might be a teacher, it might be a person of standing. But generally the notion here is that therapy should be supervised, and that supervision makes it much more likely that people will adhere to therapy, which is essential if they're going to be cured and if they're not going to contribute to the development of drug resistance. Now, this is really important not only for people's health, but we need to understand that, in fact, when it comes to the health side, as Emily noted earlier, it's much more difficult to treat resistant TB than drug-susceptible TB. It's also much, much more expensive to treat drug-resistant TB than drug-susceptible. In fact, there are places in which you can treat drug-susceptible TB for about $100 per patient, and in some of those same settings, it could cost as much as $50,000 to treat a patient with drug-resistant TB. It's much more expensive, the outcomes are much worse, and I think it's up to about 30% of the people who have drug-resistant tuberculosis will succumb to the disease, where again, as Emily had said earlier, in principle, drug-susceptible disease is completely curable provided people adhere to their treatment. TB is an opportunistic infection of HIV, as I mentioned. As the immune system declines, people might get tuberculosis. And the world has been working hard to suggest that and to try to implement the idea that everybody with active TB disease should be tested for HIV, and everybody with HIV should be tested for tuberculosis as well. Now, in addition, there are a number of measures that the World Health Organization has recommended for the management of co-infection, and these include what they call the 3 I's. The first is infection control, and that's trying to ensure that in healthcare settings, especially healthcare settings with lots of people with TB or people who are immune compromised, that infection isn't being spread in that setting. And there are protocols for trying to reduce that infection. 2 is there's the recommendation that isoniazid, which is a tuberculosis drug, be given to people with HIV to help them prevent them from getting tuberculosis. And third, there's the idea, again, of intensified case finding, as I mentioned, that people with TB, all people with TB should be tested for HIV, and all people with HIV should be tested for tuberculosis as well. Now, there's been important progress, as I mentioned, in reducing the burden of tuberculosis. On the other hand, there remain some really important gaps in addressing tuberculosis. And let me talk about some of those challenges, especially as they relate to what we call the End TB strategy. There's a new strategy for ending tuberculosis, and that strategy suggests that what we ought to aim for is a 95% reduction in the number of TB deaths compared with 2015, a 90% reduction in the number of new infections compared with 2015, and that we should wind up in a world in which hopefully no families with a member infected with tuberculosis suffer catastrophic financial losses because of TB disease. Many individual countries are working hard to achieve these goals, as is the global community as a whole. But there are a number of challenges that are going to be continue to be faced as the world seeks to achieve these aims. One is a lot of tuberculosis gets treated in the private sector, where prescribing practices might be quite individualized to individual providers. And it's going to be very important that in countries with high rates of incidence or prevalence of tuberculosis and an active private sector in medicine, that they find ways of working closely with the private sector to enhance the prescribing, diagnostic and prescribing practices of individual private providers. 2 is, while there's been important progress in developing new diagnostic techniques, it would be wonderful if we continued to see progress along those lines. Ideally, what we would find is a simple, non-invasive technique that in very rapid time could let one know whether or not the individual had any form of tuberculosis, drug susceptible or drug resistant, and to what drugs, for example, they might be resistant. In addition to calling for closer work with the private sector and the development of new diagnostics, clearly it would be a wonderful world indeed with respect to tuberculosis if Yafet or Elizabeth or Vivek, Rachel, and Emily could develop a drug that would address all forms of tuberculosis and not need to be taken for 6 months. What we have now for drug-susceptible TB, as we mentioned, is a course of therapy that's 6 months long. It's hard to adhere to. Some of the drugs don't make you feel as comfortable as you might like. And it would be a much better world indeed if we had drugs that could work, I repeat, against any form of TB through a much shorter course of therapy. We also want to, the strategy that, also calls for more patient-centered approaches and efforts at trying to ensure, as we mentioned here, that families don't suffer from catastrophic costs. It's also important that greater attention be paid to improving the techniques for diagnosing childhood TB and to developing age-appropriate drug formulations for children who have tuberculosis. By now, you're hopefully more familiar than you were before with the nature of TB, its burden, who's at risk, the important health, social, and economic consequences of TB, and what we've learned can be done to address the tuberculosis problem. You also hopefully have some sense, or the beginning of a sense, of some of the important challenges with respect to trying to achieve these global targets. In the next session, we're going to talk about malaria.